Good morning and a very warm welcome to Bonitas House Call here on SABC 2. I'm Dr Victor Ramathesele. Well, we welcome you to invite or you join us on our discussion today by calling us on the number 011-326-4740 with your questions and comments on the subject of the day, which is colostomies, or you can send your SMSs to Bonitas 33723. Now let's start by unpacking the word colostomy. Colon is an anatomical name for the large intestine, and stoma is Latin for mouth. Now, you'll remember that the body is composed of various structures, and some of these structures are tubes, such as the windpipe or the trachea, the gullet, or the esophagus, as it is called, the ureter or the urine pump, as well as the large and small intestine. Now, for a variety of reasons, which our guests will educate us about this morning, doctors are sometimes required to create openings on these tubes that lead to the outside, referred to as stomas. Now, we talk of tracheostomy, urostomy, ileostomy, and our subject of the day today, which is colostomy. Bantu bakuthi ndingasaphosisanga amasengo ke manje khwele esikadeni ke ndamkele indwendwe zethu ke abazophicotha nokuphonononga nathi ke lo mcimbi esizawuthetha nawo namhlanje we-colostomies. As we welcome into the studio Mr. Derek Mthembu, who's the Chief Executive Officer of Congenital Healthcare and a surgeon, as well as Dr. Apostle Papas, who's a gastroenterologist at the Mayo Clinic. Colleagues, thank you very much for joining us this morning. We're going to talk about something that I've always said. A lot of patients walk around with colostomy bags, and the reason for the show today is that I have discovered that a lot of them don't know exactly what these things are all about. Now, Mr. Mthembu, correct? Not Dr. Mthembu, but Mr. Mthembu.
That's correct, Victor. We're not going to go that route. I'm not a doctor, I'm a technician. You know, you don't have to be a doctor to be able to operate patients.
Yes.
Well, KwaZulu Natal, Engutu. That's where my parents are from, but we were born in Soweto. Yes, I know this is going to embarrass my children, but that's my father.
Because today ngempela ngifuna ukuthi bazi ukuthi ubani lo Mthembu esikhuluma ngaye lesikhuluma sixoxa ngixoxisana naye namhlanje ngoba njalo mase kubiza la ku Bonitas House Call awusiphoxi uyafika njalo gaga ngesince kanti uzofika ngaphambi kwami mina kufanele ngamukele wena kodwa kulungile ngalokho. Now let's talk about the colon and specifically colostomies. What actually happens and what are the reasons why you create these holes on people?
Yeah, to put it simple, as you maybe I can take you to this diagram.
Okay.
You know, to outline, I mean, if you eat, the food goes through the mouth, through the pipe called the esophagus, and it goes into the stomach where acids mix with the food, and it then goes into the intestine where it needs to be absorbed for nutrients and all that. And then what is not absorbed is going to go into the colon. This is the large bowel. And briefly, this is the right part of the colon, which is an ascending colon. That's a hepatic flexure. That's a transverse colon. That's a splenic flexure. That's a descending on the left colon. And that's a sigmoid colon. That's a rectum. That's an anus. If you do a colostomy, it means you are making an opening into the lumen of the colon and exteriorizing into the anterior abdominal wall and making a hole.
Exteriorizing, what is exteriorizing?
It means you're going to fix this onto the anterior abdominal wall skin so that the effluent or the feces no longer come through the anus, but come through this hole through the skin. As one of the stomas therapists, or Sister Shelley Govender, when he explains to the patients, he says to the patients, we are going to reinsert your backside. We're going to relocate it to the anterior abdominal wall, so that the patient understands that your backside now is no longer going to be where it is. It's going to be on the anterior abdominal wall, and the affluent is going to be collected by a bag.
Hold it there. Hold it there. Dr. Papas, now you're a gastroenterologist. You work a lot with diseases that happen in the large and the small intestine. What are the major reasons? And we'll come back to Mr. Mthembu around that, but what are the major reasons why patients will have to relocate their anus to the anterior or to the front of the abdominal wall?
The main reasons for that are when, for some or other reason, continuity or the normal movement of stool is interrupted, whether it's an obstruction from a tumor, whether it's an inflammation and an abscess for whatever reason, whether there is some or other problem that makes the normal movement of stool impossible. You've got to do something then for the patient. You've got to rescue the patient. So you've got to do what we call a diversion,
where you bypass.
You divert the stoma at the bottom, which is the anus, and you create another stoma on the abdominal wall. Okay. And that's really, in essence, what it is.
Just hold it there now. Now, our Bonitas Health House Call team went to visit a stoma clinic, which exists purely to support people with these colostomies and such like. Now, this is what they found out. Let's watch.
There are 3 groups of operations. It all depends whether there's something wrong with your large intestine, whether there's something wrong with your small intestine, or whether there's something wrong with your bladder. For instance, with a colon, a large intestine, they will do a colostomy. When there's something wrong with a large intestine, it has to be bypassed. Then they will do an ileostomy, where the stoma is in the ileum or the small bowel. Then when there's problem with the urinary tract, they will do a urinary diversion, and that will be a urostomy. For urostomies, we will have a certain bag that has a tap, for instance this one. You get 2-piece urostomies, you get 1-piece urostomies. This flange can stay on the body for about 5 to 7 days, and the bag can clip off and clip on. For a stoma made out of the colon, you get also in the 2-piece, you get a flange and a bag that goes with it. This is a disposable bag that they can take off and throw away and put another one on. Then you also get drainable bags, you get bigger ones, you get smaller ones. It all depends on what the people need. Then you get transparent bags and you get opaque bags. This is very nice because your partner doesn't want to look at stool or urine the whole time. We also have little bags that patients can use for the bedroom or for swimming, and this is for colostomies. For instance, a patient with a urine diversion will never be able to wear a bag like this. So everybody's got a different bag that they can use. There's also a lot of accessories that we can use to make life easier. Some people have dents in their skin, and then we will fill it up with a paste, or we will fill it up with a washer. There's also liquid paste that we can use. There's powder that we can use. There's lots of different items that we can use to make everybody's recipe his own little recipe. And we teach them to do it themselves as soon as possible. It's very important to empower the patient to do the stomach care himself so that he can carry on with his life. Changing of the pouch all depends on the product that he's using. We do get disposable pouches, and they can change this once or twice a day. Some of the other pouches can stay on for 5 to 7 days. Some of the pouches can only stay on for 3 to 5 days. It all depends on the condition of the skin. Some people are using a lot of cortisone, and then obviously they have a more frail skin. So it all depends on the condition of the skin. But it's important that the bag should be changed before excoriation takes place.
I mean, the sister is doing commendable work. Now, you can see from how the colostomy bag and the colostomy has to be managed that you really need a lot of support. But something that you have not explained to me, Mr. Mthembu, and we'll come back to some of the differences between the various bags that they are using there. Now, if you are removing something that is blocking, Dr. Papa said most of the time it will be a tumor or something. Why don't you just cut the tumor away and join the normal pieces together?
Yeah. Medicine has evolved and surgery has evolved as well. I mean, trying to keep up with technology.
That's good to know.
You know, I'm sure when you're in medical school, you are told that if you've got a tumor, or if you've got a patient with a gunshot rectum or gunshot colon, you've got to resect the problem and exteriorize and make a colostomy. We try to do lesser and lesser colostomy. I mean, research has shown there's enough evidence and data to show that you can resect the tumor and do what is called a primary anastomosis and rejoin it and avoid a colostomy. You can resect a short gunshot part of the colon, and you can resect it without doing a colostomy.
Okay.
I want to tell you that we're doing lesser and lesser colostomy. We want to avoid colostomy because, as Dr. Papas has correctly said, you need to remove the disease, be it tumor, be it diverticular disease, be it anything, and then if you want to externalize the colon, then you do the colostomy. Then the problem starts for the patient. You've cured the disease, the patient feels better, but now other problems kick in. Problems of psychology, problem of social problems, sex problems, and problem at workplace.
Is that what colostomies will give you as an individual?
Victor Ramathesele,
yes,
you're sitting here on your show, you're wearing your nice suit and a nice shirt, and you're not an ostoman. Imagine you had a colostomy bag.
Aye.
Maybe psychologically it will affect you. You'll never be, you know, as assertive as you are, you know, because you've not been counseled. You're sitting with people here, you know, this thing might leak. It might leak into your shirt. You know, you might be embarrassed about that. You know, you might not participate in normal activities. I mean, sex is good to have sex, you know, and you might find that with the bag, you don't want to participate in sex. I mean, you play sport, maybe you play golf, you know, you start not engaging with your buddies anymore, you know. But
why?
your disease has been cured.
Because you can see the feces.
Yeah,
what is the problem?
I mean, you see, going to the toilet and passing feces is a very enjoyable process.
Oh, is it?
It's a very enjoyable process and satisfying. You sit there in a normal way, you do your thing, and you whistle, and you walk away, you go and have dinner again.
You read a magazine or something.
Now you no longer do it normal way. You know, you've got a bag, you rely on the bag.
Okay, just hold it there. Just hold it there. Now, we also came across a medical colleague who's living with this colostomy, and he was willing to share his interesting story as Mr. Mtembu has told us. Let's see exactly what he has to say about this particular matter.
And about 12 years back, I had an ileostomy. That means the whole colon was removed and the small bowel was brought out, and I'm wearing a little bag. The diagnosis was made of cancer, very low down in the colon, so they couldn't just take a part out and fix it together. They had to remove everything. It's a big shock initially because the doctor tells you, number one, you've got cancer. And you know, despite everything, for a lot of people, it's still a very serious, nearly a death verdict. And the second thing, they tell you, you're going to have you'll have to carry a bag, and that's something you don't know. I mean, you've got no idea what's that going to entail, everything. So it was initially a shock. And the major problem is not the surgery and the operation and all that. The major problem is in the head, is accepting that this is final, and this is what you're going to do what you're going to have for the rest of your life. And it's only when you start thinking and sitting down and say, but look, if I don't have this operation, the prognosis is bad. You've got cancer, you're going to die. And then you see, but perhaps this isn't so bad after all. So it took me a few weeks to get over it. And once after that, it was, I wouldn't say it was plain sailing, but it was quite easy after that. And I think the most important thing is, you know, you've got surgeons, you've got nurses, you've got everything. But the most important thing is talk to somebody else who's got a stoma, because he will tell you exactly what is going on. He knows it, he's been through it, and that I found. Once I talked to somebody who had a stoma, my whole approach just changed.
Yeah. I mean, Mr. Mtembu has just sent this, and I mean, he has a living patient who attests to the psychological problems that go with it. I'll come back to Mr. Mtembu because clearly there are a lot of problems with these stomas, and that is why he says now surgeons are doing less and less of these things. But let's just go back to the reasons why we do them. Now, he's got, Dr. Slabber, they had a permanent colostomy. And yet my understanding is that it's something that you do because you want to rest, you know, and give, you know, certain things to heal so that at a later stage you can reconnect. But why would we have temporary and why would we have permanent colostomies?
You see, the fundamental issue there is the sphincter of the anus.
Okay.
Now, the anal sphincter is a very highly specialized muscle, and it controls the excretion of stool, it controls the passing of air, of gas. So it's a highly specialized valve. You can control it, but it's also controlled on its own by the autonomic nervous system. Now, if that doesn't work anymore, and it's just useless or whatever, that becomes a problem.
Because then it
Now,
means stool will just come out without any amount of control whatsoever.
Now that's incontinence. That's actually another issue.
Okay.
But now when you have a tumor, for instance, in the rectum, and it's very low down, then the issue arises as to what type of operation you must do. And if there's any threat of life or disease spread of that tumor to the patient, then you rather remove everything. But having said that, as Dr. Ntembe said, medicine has advanced a lot. And today, surgeons are able to actually preserve that sphincter despite tumors in the rectum. So even if you've got a centimeter of disease-free lining, mucosa, above that sphincter, if you can remove that operation and your margins are clear and there's no glands, etc., there are technical issues and there are assessment issues that have to be done by way of MRI and so on before the time to assess that patient. But doctors are increasingly trying to do less and less colostomies and sphincter sparing operations. And I must just say something at this point, not because the colostomy is the end of the world. It isn't. I think that patient explained so nicely that the problem is more here than here, because you'll find that patients become so used to having colostomies. I have many patients with colostomies that can have reversals, and they're quite happy to continue the way they are.
Well, hold it at that point, because we still need to explain exactly now when does it become permanent and when do you want to rejoin, and we need to deal with the problems that are associated with this and exactly how to avoid them. So to akhalona fela disitse ngwane se hare letlalo la motho ha le thagis ngwane se khoba matshwafo he o be pelo ya house coach. We'll continue our discussion on colostomies hanga ngare khutla papatsong ha Ramathesele. Mogaiso ga wa latlega le seng gorogile ka tlhamalalo mo thulaganya ga gago ya mamoratwa e bong Bonitas house call go SABC 2 ga go kana go golagana le rona ka tlhamalalo mo nomorong ya 011 326 4740 kgotsa magatla tsa SMS mo Bonitas 33723. Matume, you are joining us from Mpumalanga. Thank you for joining Bonitas house call. Good morning to you.
Good morning, Doctor. How are you?
Good yourself?
I'm okay, Doctor.
Yeah.
No, thanks for this wonderful show, man. I really appreciate for what you are doing for the masses. I mean, who cannot,
It's a pleasure, my brother.
Get the information like this. So I've got a question here, Doctor. You have touched a very, very important subject in the form of a colonoscopy or something like that.
Colostomies.
So, yeah, colostomies. Yeah, I've got a problem here, Doctor. I was having, a bleeding, but it started last year, November. So,
bleeding on the backside?
Yeah, on the backside, especially when I go to the bathroom to relieve myself. On the rectum. Yeah. So it started, slowly, somewhere last year, November. So I took it lightly, because I was not even bothered. But recently, I think 2 months back, it started to reoccur, frequently. And that is whereby I started to be worried about this condition. So last week I went to the doctor, and the doctor did an examination. He inserted his finger and just checked and said that no, he cannot see anything, especially in reference to blood, you see, because there was this cloth and fresh blood that is oozing after I relieved myself. And so the doctor referred me to one of the clinics or a hospital, let me just put it in that way, to go and do a procedure. So he gave me a sheet. He told me that I'm going to do what is called colonoscopy.
Yeah, colonoscopy. Yeah.
The doctor told me that they're going to insert a pipe inside my rectum and do a checkup or something like that. Then they'll fix the problem. So it's going to be a one-day procedure. But now my worry is the CEO now is speaking about the tube, the bladder, the tube that is going to be the diversion that is going to be conducted, whereby now one will be using a bag. That one is not a comfortable thing, doctor. I'm really worried about that. If it gets to that point, then it's something else, doctor. No, get you too much,
No, Matuma, I can say our cats here because what you are saying.
No, you are right, doctor. Hey,
it's very predictable.
Now, when you go to the bathroom, that is one of the most wonderful moments.
I learned it for the first time today. But so many people are saying actually going to the bathroom is enjoyable. But hang on, Matuma, Mr. Mtembi is there. He's a. I don't know why he's not a professor just yet. He must still explain to me that. But he's one of the best teachers when it comes to this area. Now, Matuma has got a problem. Clearly, it needs investigation. Quite rightly, his GP has referred him to a surgeon to go to do this colonoscopy. Now, are there any questions that you want to ask Matuma before we attempt to give him some advice?
No, I don't. I'm not going to ask him a question. I think he's a very good storyteller. Matuma has told us that he passes fresh blood, sometimes with cloths when he goes to the toilet. Most of the colonic problem or the GIT problems can present with PR bleeding, blood, per-rectum bleeding.
Yes.
Or so it is important that as doctors, after we've taken history, we've done systemic inquiry, we've examined the patient, we try and ascertain where the problem could be.
Yes.
And then after that, most of the time we would have known where the answer is, and we do investigation. And one of the investigation Matuma says they've recommended is to do a colonoscopy. And a colonoscopy, you put a pipe with a camera. You look at the anus, you look at the rectum, you look at the colon, you go all the way, splenic flesh, a transverse colon, you end up in the cecum. You want to pick up whatever problem is. I mean, without scaring him, it could be piles, and piles you won't need a colostomy. It could be other diseases where you are bleeding from here, which can be controlled. It could be benign diseases like polyps, which can be removed during the same procedure, and you're cured. And unfortunately, in medicine, we want to exclude malignant diseases as well.
Or cancer, as it were.
Cancer. It could be a tumor sitting there. If you've got a tumor sitting there and you do nothing, a cancer sitting there, you do nothing about it, it decreases your possibility of living, Matuma. And doctors want to make sure that they'll remove this tumor to improve your quality of life, to improve your chance of living, to improve your 5-10-year survivor. And unfortunately, if this tumor maybe is sitting in the rectum, going all the way into the anus, you might need to remove the whole thing and have a permanent colostomy. But sometimes you can get away with the temporal colostomy that you can reverse. So Matuma needs to sit down with the doctor after he's been done a colostomy and be explained exactly what is the problem. I mean, the stoma therapist needs to be there, the psychologist needs to be there, the nutritionist needs to be there. If Matuma is going to need to do
he might not need a colostomy.
He might not need a colostomy.
So, but first a diagnosis has to be made, and that he's going for a colonoscopy is actually the best decision he has made ever, because that will at least give us a sense of what is wrong with him. And he might not end up with a colostomy, but if he does, if he sits down with the doctor, they explain exactly why it is done, if he's given the psychological support and how to look after it, it is not a bad thing after all. But further, you guys as surgeons, you want to discourage colostomies now. You're trying to see if we cannot do without.
I can add, a few weeks ago, I had a colostomy colonoscopy myself, Matuma, because without revealing my age, I'm that other side for screening purposes. I went in, somebody put a finger there and they did a colonoscopy, and luckily for me, there was nothing wrong. And I've been buying it.
I think we've explained it very well to Matuma that he is unlikely to have it, but if he does have it, there'll be support, and there'll be all the reasons to make sure that he understands, and then that the psychological issues that are dealt with and the social issues associated with the colostomy can be dealt with. But tsona ba re tla re ke dipitsi ka mebala ba di bona ba re tla re ha di tswa mo kwatong ga de ba sotho bona ba kitla ba re re tla boka ha di oro ka di welcome tani ya kuthiwa sizoyicela ifuthiwe ake sicela kulo mfowethu ohlangabezana nalenkinga.
The beginning of the year 2008, if my memory serves me very well, what happened was I felt some sort of a little pain at the backside. There's no other way I can call it, sorry, on the S. Yeah, I can say colon. There was pain there. Then when I went to my GP, a general practitioner, he diagnosed as piles. Yeah, we call it piles. And then he gave me piles medication. Weeks later, 2 weeks later, the pain came back again. Now it was severe at that time. Now it had also blood. When I had to go to the loo, there was blood soil coming out, and then there was severe pain. I went back to him, and then he referred me to a specialist in Little Company of Mary, where I met Dr. Ramathesele. Dr. Ramathesele diagnosed me with colon cancer because they found out there was a lump or a tumor that was coming out at the backside, and it was growing fast. And it was growing fast, and also there was blood coming out. So I needed to be taken to the theater for operation. The first few 2 years to 3 years also were very hectic. I couldn't understand myself. I couldn't understand my body. Nobody did, because even the surgeons themselves couldn't understand how would I, in my age, could have contacted something like this. I was angry at myself. I was angry at the situation around me. I tried to commit suicide at times, and that didn't happen.
I think it's very easy to underestimate for us doctors the effects that some of these procedures have on our patients, driven by our quest to save a life. You want to remove the tumor, and because you think the tumor is an identified matter that can actually lead to shortened life, as you explained to Matume. But this guy actually contemplated suicide at some point.
Yeah, Dr. Victor Ramathesele, the incidence of depression and suicide, it's among patients who have had colostomy. It's an unnatural way of going to the toilet, as I told you. Coloplasts, they define these patients as patients with intimate healthcare needs. You know, it's like patients who've got difficult to heal wound who are smelling. It's like patients who are incontinent of urine. You've got special needs, and these patients need special attention. You see, we surgeons, we sit on the altar and we dictate to people what to do. We do colostomies. We don't cancel patients. This needs a teamwork. Before you do a colostomy on a patient, you need to cancel this patient. You need a specialized stomatherapist like Shelley Govan that works for Coloplast to tell these patients what are their expectations. And you need to be able to manage these patients throughout this problem and give them a proper bag that it's not gonna leak feces. It's not gonna hurt the skin. You must make sure that this bag sticks well and it doesn't leak. And you continuously cancel this patient. You see, me and you, we can eat whatever we like. Sometimes we go for a curry and we get a little bit of diarrhea. It's okay, you know, we can live with that. Somebody who's got a bag now, he's got a diarrhea, he's sitting on your show like this, he's got to change this bag all this time. His life is messed up. Some employers don't understand somebody with a colostomy bag, you know. How are you going to work? How are you going to go underneath the mine? How are you going to do manual labor if you pass his feces all the time?
Just hold on. Just go to Doctor, does it smell?
Oh, yes. Oh, yes, it can smell. You know, if you take it off, it can smell. But, you know, if you look after it, there's certain things you can use even to get less smell, or your diet, etc., etc. But that's not a problem. You know, when it's properly put on your skin and you look after it, you smell nothing.
We'll continue our discussion on this very, very interesting subject of colostomies when we return. You stay with us. Welcome back. You're watching Bonitas Sounds Comedy here on SABC 2. Now, it is quite obvious that there are a lot of psychological and social issues associated with these colostomies and various other artificial anatomical openings that have to be performed on our bodies to manage a variety of medical conditions that we're talking about today. And whether they are temporary or permanent, clearly, the management of these colostomies is not easy for patients, it's not easy for caregivers, and it's not easy for family members. And let's see evidence of this.
I met Sister Naomi Nettling through Dr. Ramathesele, my specialist, the surgeon himself, in Little Company of Mary, because she was the one who was supposed to do the portioning on my stomach, where I'm supposed to be cut for theater purposes. That is when I met her, and after the operation, she was the one who was taking care of the bag, showing me also how to change it at times that she wouldn't be available. And at times she would also, you know, show me how to cut it into proper sizes and how to place it on my belly. And when I need to rechange it, how am I supposed to rechange it? And if at times, because the soil doesn't have to have contact with the skin, how to properly deal with the sores themselves. In a positive manner, having a colon bag has changed my life in a sense that it saved me. That's the first part. Because if they didn't do the bypass, I would have passed away by now. So it saved me so that I can be able to release myself through it. And negatively, I would say it hasn't, in a sense that I was in contact sports and now I can't be able to. My message to the other people that are going through this disease, or not this disease, or going through difficulties, physical or otherwise, is they shouldn't give up on life. It is understandable by a person that he or she can hate himself, he or she can question himself what happened to him, why him or her, and then he would despise the Lord for, you know, making him or her that way. What I can say to him, it is understandable at initial stages, but each person needs to know, why not him? Ask your question, why not you? Why should it be somebody else? The only thing is just be strong on your own self first. Somebody else, which is your friend, your family, your fiance, your wife, your husband, your friends, they will support you only if and only when they see that you've been positive about how you're living.
May he live long. I mean, he was very fortunate that he was symptomatic and the cancer was picked up at an early stage and the operation was done. Of course, he battled at the beginning, but it does look like what Mr. Mthembu was explaining, that this is a team approach. You need to have the nurse, you need to have the psychologist and everybody else. But it seems to be working for him. But I'm worried here. I mean, he's not the first young person that I've met in recent months who has been diagnosed with colon cancer. Now, this is a cancer that was not particularly common among Africans. What has happened? What has changed? Or is my observation right in the first place?
It's a difficult question because I don't know that we've got real statistics to show exactly what the incidence was and is. But there is no doubt that colon cancer is becoming more common. And then we must also remember that we didn't have colonoscopies many years ago. So these things were not picked up so early. But I think that the environmental factors, the diet, etc., stress, probably also plays a role. So that is also an important factor. That patient, I must say, I admire him. I think he's a perfect example of someone who's handled the situation so exemplary. He's well informed, he's adapted, and I think he's a very impressive patient.
Mr. Mtebi, you spoke about gunshot abdomen a little bit earlier, and I don't want to create an impression that colostomies are done for cancer patients alone. Now, in patients, you can explain to us using the diagram, in patients who have been gunshot, which is quite common, and other types of trauma to the abdomen, why would you do a colostomy there?
Like I said, we try and avoid doing colostomy. When I was a student or a registrar at Chris Hani Baragwana Academic Hospital some few years ago, it was quite routine for us. After the patient has been shot anywhere in the colon, to try and resect that part of the colon and take out that loop of the colon as a colostomy, or you could do what we used to do, double barrel, or you could do a Hartmann procedure where you close the distal part and the proximal part to take out as a stoma. It was normal because we thought if you do a primary anastomosis, the things will leak.
So
and
if you take the damaged part away and join the normal parts,
it will leak.
Okay.
But I mean, time, and it has proven that you don't need to do a colostomy anymore. It means we're doing unnecessary colostomies.
Okay.
So now we join this part. Okay. But you might find that the colon is shattered on many occasions, and the patient is unstable, you know. It's not good to keep on operating the patient who's unstable, who's bleeding from somewhere else. You know, you want to do what is called damage control, and you might need to just do a colostomy, which you'll reverse when the things are normal, you know, during the day of the light, you've resuscitated the patient, you've given blood.
Then you can join the normal parts again.
You know, you can go in back and re-anastomose.
Just hold it there. We'll continue our discussion on colostomies, provided you stay with us. Welcome back. One is Bonitas house call for SABC2. And today we're talking colostomies. We are joined by Sizagele from Tutuza in Niger. Thank you for joining Bonitas house call. Good morning. Sizagele. Caesar. Okay.
Hello.
Yes, Caesar.
Hello, kunjani?
Usekhona kunjani sisi wami?
Ngiyaphila. Benginomntwana, ngine-problem ne. Ngiyangaba nomntwana bazamenza i-colostomy ephuphuma eChadani last year ngo-October. So bathi bazoyenza i-closure after 6 months. Ngambuyisela after 6 months for i-closure. But bantu bajikisa. Bathi nge-9 months base bayangenza the very same day. Wasuyashona the very same day.
Oh no.
Angazi ukuthi problem yaba yini ngoba i-first operation ihambe kahle. Azange yangihlupha. Bengumntwana nje vele beka-disabled.
Manje siza
the very same day.
bathi bebenzelani i-colostomy yini inkinga yakho baye bachazela ukuthi kade kuyini inkinga
Bashilo ukuthi amathumbu akhe lele linye ele-toilet alikhoni ke-toilet lelinye lihleli phezu kwalo. Bathi bamenza operation ngoba vele beyangakhoni ukuya kahle e-toilet.
Okay, so uye wafaka i-colostomy bag waze wahlala waze waba yi-9 months bathi masomphindisela esibhedlela ukuthi bayisusa bavale ushone sekayenzile operation esibili noma kanjani
ile yesibili and uyenze same day washona same day but ngiyangacakeka ngoba makabuye ku-operation ubuye ngikhona vele ngesikhathi sevakashi ngo-6 mina ngimshiye ngimbona ukuthi usesedizi yabona Yeah, so azange ngibona amasayini ukuthi vela angazashona, but benginganasayini ukuthi uzoshona.
Ngane kwethu ngiyadaba ukumana ukuzwa ukuthi izingane seziyalahlekelwa impilo ngaleyo ndlela. Uma yakho lalo ngoxolo kodwa ake ngibuze umvelase la mhlawumbe uyosichazela kahle. Kusuke kwenze njani umvelase ingane when you have an infant having the need to do a colostomy, and unfortunately for Sizakela's daughter, she died when she went back 9 months later to correct the colostomy and reanastomose or rejoin the large intestine. What could have been the problem?
Yeah, we're sorry for her loss, but if I teach students, I usually say the causes are usually congenital.
Yeah.
The reason to do colostomy, they're congenital or acquired.
Okay.
There are congenital conditions that you inherit while you are in the womb that make it not possible for the feces to go the usual route. One of the things, there might be malformations of the colon. It happens while you are in utero.
There were many abnormalities that the child was born with.
There could be atresia, where there's obstruction here. This part of the bowel didn't develop well. Or during the rotation, it didn't rotate okay. Or sometimes you're born without an anus. Sometimes you're born with a colon. The nerves that are supposed to control the contraction here are not there, which is hair-sprung disease.
I see. And then the feces cannot pass through.
They cannot pass through. This child is born with a distended abdomen. You know, this child is vomiting, you know, I mean, as a neonate, you know, and some of them might be born prematurely. And these children usually might multiple congenital diseases. They might have atresias or other multiple congenital diseases. So you resuscitate them as a neonate.
Atresia is when there's a natural blockage.
There's a blockage. I mean, it means it never developed.
Yeah.
So what do you need to do? As part of resuscitating them, you take them to theater, you correct the fluid, and then you exterize bowel. You take out this colon so that feces can continue. And you wait for this kid to grow with the colostome. You teach the mother how to look after the colostome, and let this child grow. And as this child grows, is a little bit bigger, it's easier to operate. You can do more studies and see exactly what's the problem. If there is no anus, you can be able to try to make an anus. Sometimes the colon ends up there and the anal canal there, you might need to join the two. Sometimes if H-Sprung disease, you might need to resect that and then re-establish continuity.
One could have led to the death of the child. I mean, of course, she doesn't know, but what could have gone wrong?
I'm not going to go through that lane. I don't speculate, and I'm not going to speculate. There is no minor operation. I mean, I've told you before that patients go for tonsillectomy, they even go for circumcision, and things might happen which are anesthetic related. But let's not go, let's not speculate. I'm not going to try and speculate what made the child, but all that I'm saying, this child, as she said, this child might have other malformation. He might have other cardiac lesions, you know, which were more serious than a colostomy. He might have other lesions somewhere else. You know, we need to get the entire story, and I'm sure because it was a natural death, they must have done a post-mortem to find out what is it. It's just that we don't talk to our patient. She must go back to a caring doctor who's going to take her through, and maybe if she wants to create a closure, she can go and
because
they can
that's what
tell
she
her
wants.
What's the problem.
It's the closure that she wants. Just before you go to the end break, now clearly these surgeons don't want to do less and less and less of this. What are the reasons why? He's mentioned a lot of the psychological. What are some of the problems that are related to a colostomy other than the psychological problems, which we are under no circumstances going to undermine?
Well, it is an unnatural process, let's face it. So I think a lot of patients don't like that. But then there are practical issues. You know, if you have an ileostomy, for instance, you know, there you have a high volume stoma. And, you know, there you have like more than half a liter, you can have a liter plus of fluid, it's more fluid. And that can become, it's got digestive enzymes and so on, and it can cause leaks and excoriation of the skin and so on. It's expensive. You know, it's not a cheap.
Let's hold it there, because when you come back, we have little time. We want to talk about the recent advances and how we can move forward with all of these complicated things that Mr. Mthembu and his company are accustomed to doing on a daily basis. We'll come back and run up our discussion on colostomies when we return. are back. You're watching Bonitas House Call on SABC2, and we are talking colostomies. Dr. Papas, your closing comments.
I think that we must understand that colostomies are nowadays becoming more and more rescue procedures. Even illnesses that previously needed total colectomies are becoming far more effectively treated today. So we must understand that it's often a life-saving procedure, but what also people must understand is that it's not the end of the world to have a stoma, a colostomy, ileostomy, or whatever. Life carries on. There are people that have lived for more than 50 years with a colostomy. Perfectly normal. It's not going to make you die sooner.
Okay. Mr. Mthembu, your closing comments.
Yes, the buzzword, minimally invasive surgery, keyhole surgery. Colostomy can be done laparoscopically, which makes the patients
without
feel better.
Opening that Mr. Ramsey there,
without tatamula the patient. You do through a keyhole, you can do that.
Okay.
But the important thing, Victor, you've got a beautiful watch there. You've got beautiful things there. You know, they're as good as the support that you get. If this watch doesn't work and you cannot take it anywhere, it's useless. You've made a stoma on the patient. There's a coloplast care program where they follow these patients from the hospital to their home situation, to the community, you know. And these patients, when they've got problem, they can call into the call center, you know, to make sure that these patients live a reasonable life.
And they'll get support from that call center.
They run this program in public, both in public and private hospital. Patient comes from Paperstad, you know. I mean, this patient doesn't know what's a colostomy. The support system is not there, but these patients, they can access. It means the nurse can follow the patient into the community. The patient can call through. It's called Coloplast Care Program. And I think we must embrace that program.
And in all languages?
In all languages.
Oh,
and these patients can phone ngesiZulu, ngesitswana. There's somebody in there.
Yeah.
There's booklets that they give to these patients that is written in their own language, so that these patients can enjoying the things that they enjoy the most in life.
Mr. Derek Mthembu, thank you ever so much for gracing our studios this morning and giving us so much education and information. Same to you, Dr. Papa.
Thank you, Dr.
We'll meet again because there are a lot of those gastrointestinal conditions that we need to talk about on Bonitas House Call. But that is, rona bohle barati ba tshehetsi ba thaseli ba khothumetse ka sitana le ba manukeng ba lenaneo le. Tanki hangwe, tanki habedi, tanki hararo. Ile har dira di khala rona he re meno la tlhabela. We'll be back next Saturday with how to choose your medical aid. Very important subject this time of the year. So don't miss it here on SABC2 at 8:30 in the morning. Tato Haidam Ren. Thanks for joining us today. And for me, Dr. Victor Ramathesele, ke mo chane mo chicha, ke mo chana maswati, ke na mane setla mo tangwa mletsa. You take care.